Hey guys, welcome back. In this topic, I'm going to explain about cardiomyopathies, and the first one on the agenda would be the commonest one that we encounter in clinical practice, that is hypertrophic cardiomyopathy, and a subtype of it which is called as hypertrophic obstructive cardiomyopathy. Now, this happens to be the commonest one that we encounter in clinical practice. I know that the pathologist has taught you, and Robin says that the commonest one is dilated cardiomyopathy, but we'll go by what Harrison says here, that hypertrophic is the commonest one. The pattern of inheritance behind development of this cardiomyopathy is autosomal dominant, and there's a gene which is abnormal which results in this malformation of the heart, that would be MYH7 gene, which would be sitting on chromosome number 14. In fact, when you will study regarding this topic, the textbook is going to say that there are 6 different genes sitting on 4 different chromosomes, and there are 50 different mutations which have been ascribed to causing this cardiomyopathy, out of which I have described the one that is the commonest one and was described way back in 1989. Now let's look at what's the problem in the heart of this patient, where I have put a yellow star mark. This is asymmetrical septal hypertrophy, and this will explain the episodes of chest pain in this patient, because this, I can say, is useless muscle in the heart. It would be consuming more oxygen, but it will not be contributing anything to the cardiac contractility. Therefore, asymmetrical septal hypertrophy is one of the primary reasons for subendocardial ischemia in these patients. Even the free wall of the left ventricle, if I just mark here, the free wall of the left ventricle of this patient is also thickened, and more is the thickened left ventricular wall. In fact, you will hear me subsequently saying that in these patients, if the left ventricular wall thickness is more than 30 millimeter, there is an increased risk of sudden cardiac death in these patients. A lot of these patients can develop tachyarrhythmias and can die because of worsening of the subendocardial ischemia, which is due to combination of increased free wall thickness of the left ventricle and asymmetrical septal hypertrophy. In fact, the cavity size of the left ventricle of this patient, though the heart is anatomically bigger, because I'm using the word hypertrophic, no, so the heart is anatomically bigger, but the cavity size of the left ventricle is even smaller than the left ventricle of a normal person. Therefore, in these patients, there would be a diastolic malfunction in the heart. Yeah, I agree that because the name is HOCM, there will also be a systolic malfunction occurring, but the primary defect in the heart of this patient should be answered as a diastolic malfunction, which will explain why you get syncopal episodes in these patients, because if the cavity size of the left ventricle is smaller, it will receive less blood. If less comes in, less would be going out, and therefore, especially when these patients are doing any strenuous activity, there is a high probability that they could either develop a pre-syncope or a syncope as well. Another very interesting fact that we encounter in these patients, and for which I'll just zoom into the image slightly, is that in these patients there is no problem at the level of the aortic valve. But right below the aortic valve, there are 2 problems that are occurring. One, where I put the yellow star mark, you can notice the septal hypertrophy. And the second problem in this patient is a systolic anterior displacement of the mitral valve. Because the heart is malformed, even the mitral valve position is a little displaced from where it originally should be. And the combination of the two create a tunnel slash a funnel right below the aortic valve, which will limit the amount of blood going out of the left ventricle into the aorta of this patient. So I can say 2 terminologies here. One, hypertrophic cardiomyopathy would be an example of subvalvular aortic stenosis. As I said, the problem is not at the aortic valve but below the level of the aortic valve. Apart from this subvalvular aortic stenosis, I also said that in this patient, the mitral valve position is a little displaced. In fact, I will be saying this term even when I describe the echocardiographic findings of this condition, that is systolic anterior displacement or systolic anterior movement of the mitral valve, and the combination of the two, that is the displaced mitral valve and the septal hypertrophy, is responsible for what would be written in the textbook as a left ventricular outflow tract obstruction. As I said, there's a funneling, there's a narrowing, which will limit the amount of blood that goes out of the left ventricle of the patient. So you can see now 2 problems. One, less comes in, and the one which is lesser inside will have problems in going out. This is because during the phase of systole, there is a combination of septal hypertrophy, which is the asymmetrical one, and the systolic anterior movement of the mitral valve, which results in a dynamic left ventricular outflow tract obstruction. And the importance of this you will realize subsequently when I describe a specific type of pulse that would be encountered in these patients. Because there is an increase in the free wall of the left ventricle of these patients, chances of sudden cardiac death are dramatically increased. In fact, from the pathology perspective, I would also like to draw your attention to the fact that the lower end, if you look at the green marking that I've done at the movement before you, I can say the fact that in hypertrophic cardiomyopathy, the lower section, the cut section of the left ventricle looks like a cut end of a banana. So another pathological correlate before I begin the clinical details of this particular topic would be banana shaped cavity. In fact, this could be a one-liner question. Banana shaped cavity of the left ventricle is a feature of. Your answer would be the current topic of interest, that is hypertrophic cardiomyopathy. Once you get these 6 points imprinted in your brain from the pathological domain, I'm going to next explain to you how the case would present. So let's look at the clinical features. This is a young guy. He's approximately 20 years of age and he's just started going to college. And in this chap, the earliest symptom that would be occurring, or the most common symptom that would be occurring, is a dyspnea. Now, why would you be having a dyspnea in this patient is because the left ventricular end diastolic pressure would be increased. Why? The reason for that is hypertrophied muscle. If you increase the end diastolic pressure in the left ventricle, the blood from the left atria will not be able to go in the ventricles. And if the left atrial blood cannot go in the ventricles, then there would be pooling of blood in the lungs as well. That will explain the pulmonary edema component of this patient. The dyspnea that is occurring in this patient is not because of a systolic malfunction. The primary problem of dyspnea is due to diastolic malfunction, because I said that the left ventricular end diastolic pressure is increased, and this could be measured when you are doing an echocardiography and a Doppler of the patient as well. The second complaints of these patients would be chest pain. This is because of the asymmetrical septal hypertrophy and the increased thickness of the free wall of the heart. This chest pain would be accentuated on exertion, but make no mistake, could be present on rest in these patients as well. Now, a lot of these patients will say that if I have to do any kind of activity, like for example, this person stays on the second floor and his mother asked him to fetch vegetables from the market. This chap, he will have difficulty in doing this task, like he has to carry a 10 kg bag of sack of potatoes up to the second floor, so he will not be able to do it. There would be effort intolerance. In fact, in these patients, if they strain themselves too hard, there's a probability that they might develop syncope, or they could be pre-syncopal episodes in these patients as well. And most of the time, I would say this 20-year-old guy does not participate in any athletic activity or sports-related activities. Even he says, like, when I go to a marriage party, like my cousin's marriage occurred, and like I was dancing at the marriage party and I became unconscious. And he says, doctor, my cousins or my friends make fun of me because every time I try to do any strenuous activity, or by strenuous, I'm not talking about extreme amount of physical activity, something as simple as dancing at a marriage party, he says, I become unconscious and then everybody makes fun of me. This particular chap normally does not participate in any sports related events also, but today in his colony, there was a football match and his colony team was short on one guy. So normally his friends make fun of him because he's not able to run as fast as them, so they don't let him play in a football match when there's a inter-colony match going on. But today, because his team was short on one guy, his friends told him that today is your lucky day, you get to be on the team. And this guy is super excited. Maybe he even invited his mom or dad, or maybe asked one of his friends to make a small video of him with a mobile phone while he's chasing the ball. Now, once the football match is on, you very well, like, as children, you would have played football, or I'm not talking about any competitive level football, maybe in your colony, just playing around with friends, knocking the ball around. I mean, this the thrill of it. This particular guy, he's happy, he's trying to chase the ball, he's running fast. And then he collapsed on the pitch, and everybody thought that he had fallen accidentally. I mean, this chap, he had collapsed on the pitch, And the player who was closest to him, he thought that he has fallen accidentally. The opposition team took over the control of the ball and the match has continued. I mean, the referee did not stop the match. Everybody thought that this guy has tripped accidentally, and the player closest to him called out his name and said, "Buddy, come on, get up. Match is continuing. Maybe the opposition team might score a goal." And this guy did not respond. So his friend, out of curiosity, just ran up to him. He was maybe 10 meters away. So his friend ran up to him, and he found that this chap was lying face down on the ground. And when he turned him, this guy's lips were deathly blue and he was not breathing. His friend freaked out, non medical people freaked out. Maybe they brought him to the hospital, or maybe they were aware of some kind of CPR. Maybe they learned it in school. So they tried to do some basic CPR in this guy, but this guy did not survive the journey to the hospital. On arrival in the hospital, the doctors declared him brought dead. What I have explained to you is a very unfortunate scenario. I have described sudden cardiac death in a young guy who is playing football with his school friends or college friends or in the colony match itself, and everybody is in a shock or is in a daze trying to know what really happened. In fact, the question that arises here is, why did this young guy die suddenly? And this is obviously not myocardial infarction, because if he would have suffered chest pain, he would have at least cried out with chest pain and then he would have collapsed. It was his friends are saying, "Sir, he was just chasing the ball, suddenly collapsed, and then we found him lifeless." So if he says, what is the cause of sudden cardiac death in these patients, then your answer would be given as ischemic ventricular fibrillation. A large number of these patients are always told to avoid competitive sports. This is because either they can develop ischemic ventricular fibrillation or they can develop a PVT. What is PVT? It is pulseless ventricular tachycardia. In fact, it may not be a scenario for football match. He might just say that this guy was playing basketball and he died suddenly. Or let me say, this guy is fascinated with bodybuilding. He's not a bodybuilder by any chance. He's just fascinated by bodybuilding. So one day he just went into a gym, and on encouragement of his friend, he tried to do some weight training or he tried to do some bench press. Now his friend, who's physically strong, is doing bench press or twice his body weight. So he just gave him a challenge. Like in a gym, if 2-3 guys are doing exercise, they might challenge each other to repeating the same number of sets with a higher level of weights. So this friend of his innocently, not that he's trying to, ridicule him, just innocently asked him, "Okay, buddy, why don't you try exercise and why don't you?" Because they think that he's a weak chap. So his friend told him, "Buddy, why don't you try these weights or why don't you try some bench press?" And he's trying to do this gym workout on support of his friend. And because his heart is not designed for doing a gym workout, this guy died accidentally in the gym. The reason for this is again ischemic ventricular fibrillation, because there is useless muscle in the heart. It consumes more oxygen, does not contribute anything to the cardiac contractility. It's just the useless cardiac muscle is just sitting there eating up more precious oxygen. So if you get a question that says a young guy playing football and he dies suddenly in a colony match, in a football match, it is hypertrophic cardiomyopathy, and questions to this effect have been asked in the exam in the previous years. Now, before we go forwards, I would like to you guys to remember that there could be a slight change in the terminology in multiple choice questions as well. Because sometimes the question will say, what is the most common sustained tachyarrhythmia which is encountered in patients of hypertrophic cardiomyopathy? The moment he uses this word, sustained tachyarrhythmia, you see, ventricular fibrillation cannot be sustained for minutes. In ventricular fibrillation, a person is going to die within 4 minutes, or maybe somebody will go in with the CPR and defibrillate this guy and he will be saved. In ventricular fibrillation, it cannot be long standing. Within 4 minutes, it's game over. Either you are able to save the patient or the patient dies. In majority of cases, patient will die. But if he says the word sustained tachyarrhythmia, which is encountered in a patient of HOCM, and even if he changes, instead of saying hypertrophic, he says dilated cardiomyopathy, restrictive cardiomyopathy, and he uses the word sustained tachyarrhythmia, then your answer would be given as atrial fibrillation. So mark my words there, guys. If you read a question that says sustained tachyarrhythmia in a hypertrophic cardiomyopathy, your answer would be given as atrial fibrillation. But if it specifies the word sudden cardiac death. He's giving you the scenario that the guy is chasing after the ball passionately and to the max of his capacity, and then he collapses suddenly. Then it would be a ischemic ventricular fibrillation. And well, his family is in a shock that he died suddenly. And that is when you might be having a father or a mother telling you that even his elder brother or sister was having similar kind of complaints. Like his elder brother also used to have syncopal episodes and he also died. So every time you read about sudden cardiac death in a sibling, then you always have to think in terms of possibility of hypertrophic cardiomyopathy. Though during the course of these videos, you will also hear me talking about genetic conditions like Wolff-Parkinson-White syndrome, Lown-Ganong-Levine syndrome, where again there could be sudden cardiac death in a sibling, brother, sister mentioned in the question because they also have a genetic basis. In fact, lots of time, on YouTube or on social media, you would be having these videos where a young guy, let me say he's the bridegroom, he's getting married today and he's dancing on his own marriage party and he suddenly collapses and dies and everybody's in a shock. A young guy, supposedly previously healthy from the parents perspective. I mean, though he was having physical problems which he was not able to explain properly, or I can say that because of this breathlessness and chest pain, he used to restrict his physical activity. On marriage party he was dying, he was dancing and he unfortunately expired. So these kind of scenarios do become viral on social media nowadays. Now, once we have taken care of the clinical history, our next objective would be to check out the examination findings. So I am assuming that this guy has not died in a football match. Luckily for him, he's not died in a football match, or he never played in a football match, and he came to me prior to that for a routine medical checkup. A young guy, 20 years of age, breathlessness, chest pain. He says, I avoid physical activity, doctor, and he's doing it rightly so, because I am going to tell him competitive sports are not for you. Even in a colony football match, passions run high, tempers run high. We always want our team to win. So I don't want this guy to stress his heart out. So what is the examination finding that I will encounter in this chap so that I can tell him that competitive sports is not for you, is with respect to pulse. And for this, I would like to give a short description. So kindly be patient and hear me out. At the moment, I'm just drawing this pulse tracing where I have shown the heart sounds S1, S2, and S1. And then in you and me, whenever you are checking the character of the pulse in the carotid artery, we would be having the peak of the pulse being generated in the middle of systole. Then we have is a dicrotic notch and the pressure will fall. This is itself a physiology question. That dicrotic notch is going to be present with respect to, in fact, the question will say dicrotic notch in physiology will be present after which heart sound. So you can see from the diagrammatic representation itself that the dicrotic notch will be present right after S2. Now let us see what happens in a patient of hypertrophic cardiomyopathy. The first word that I would like to put up here is hypertrophy in the heart. Because of hypertrophy, the pulse of this patient will literally take off like a rocket. So first I'm going to say that the pulse of this patient will exhibit a fast rise. Why I'm saying this fast rise is because initially there's a lot of muscle in the heart that can generate the force. But then would come the problem. And the problem in the heart of this patient, as I explained to you, was a left ventricular outflow tract obstruction, which was due to combination of two things. I'm going to just move up my slide and bring the diagram to your notice once again. You can see that when the blood has to go out from the left ventricle towards the aorta of this patient, this is the route that the blood would be following. And you can notice that there's a tunnel. This tunnel is created due to two reasons. One is the systolic anterior displacement of the mitral valve. The mitral valve is abnormally placed in this patient. The second is the hypertrophic cardiomyopathy component. The combination of the two will act like a speed breaker, and this speed breaker will decrease the ejection velocity temporarily. Let us assume, if just to simplify things, you are driving your bike over a speed breaker, or let me say you're driving your car over a speed breaker. Now, when your car will go over a speed breaker, you will be suddenly feeling a jolt. That jolt will be because suddenly there's a deceleration happening. That is what is happening here as well. In this patient, you will notice that the pulse will be showing a fast rise followed by a fast fall. Now, obviously, subsequently, the momentum will ensure that the blood will be able to go out of the heart of this patient. So if you see the tracing of this person, It is not that I'm saying that the blood will stop going out of the heart of the patient, but as I said, like your car is going over a speed breaker, you feel a jolt. That jolt is because of the deceleration, and that deceleration is what I've tried to show here. So when you're going to check out the character of the pulse of this patient, it will be exhibiting a fast rise and then a fast fall as well. In fact, to describe this fast rise and a fast fall, Harrison has used a casual term, jerky pulse. So when you are going to check out the character of the pulse of a patient of hypertrophic cardiomyopathy in your exam, you will be using the technical term. The technical term that you will be using is pulsus bispherians. Now, the way they teach pulsus bispherians in a medical school will be that it is a twice beating pulse in systole. Normally, pulse, when you feel it, we don't say it is twice beating. I mean, there's a single peak of the pulse in middle of systole as I've shown in red. But in this patient, you can see two peaks. What you are able to feel, however, is not the second peak. It is only the first peak. And when I'm describing the first peak, I said the sudden rise due to hypertrophy and the fast fall, which is due to the left ventricular outflow tract obstruction. This initial peak that you feel is what is written in Harrison as a jerky pulse, or what we call as pulsus bispherians. The second examination finding that you will encounter in this patient and would be a good pickup point will be this word double apical impulse. Well, let us now understand why do you get a double apical impulse in this patient. You see, apical impulse would be primarily because of the force generated by the left ventricle, but in this condition you also get a left atrial hypertrophy. The reason for this left atrial hypertrophy is that the left atria has to work harder because there was extra muscle in the left ventricle. I said left ventricular end diastolic pressure was higher. Because the end diastolic pressure is higher, therefore the atria has to work against a resistance, and therefore these patients also have is a concomitant left atrial hypertrophy. And this left atrial hypertrophy against a non-compliant ventricle is responsible for the double apical impulse. To understand this better, let us say if you listen to the heart sounds topic, I have explained that atrial systole occurs during the phase of ventricular diastole. You see, during ventricular systole, you will obviously get a apical impulse. That is okay. What I am saying is just before ventricular systole, when there is atrial systole occurring, this atrial systole will also be appreciated by you. The left atria of this patient is hypertrophied, so it generates a second impulse which would be coming right before the impulse generated by the left ventricle. I repeat again, atria contracts before the ventricles would be contracting. So because the atria of this patient is generating higher pressure and more force than what would be a normal pressure generated by left atria of a normal person, this extra pressure would be perceived by you as a second apical impulse which would be coming right before the ventricular systole. To simplify things further, he might even use the word heaving apical impulse. Either of these two terms could be written in the question and would help you understand that there is a hypertrophy of the heart. Then he might even talk about second heart sound. For second heart sound, what you need to remember is that in second heart sound, there would be two issues. That is aortic and pulmonic valve closure. I mean, aortic valve closes first, then pulmonic valve. And the usual time lag between the two is approximately 30 milliseconds. Now, in this patient, what's going to happen is that the exit of blood out of the heart will take extra time. The reason why I'm saying that is that because there was an outflow tract obstruction, even though there is less blood coming in the heart, that less blood will take extra time. I repeat again, there's lesser blood in the heart, but that lesser blood will take extra time to go out of the heart of the patient because of the outflow tract obstruction. So the aortic valve will close later, and when the aortic valve will close later, the gap between the aortic and the pulmonic valve closure will become relatively lesser. That is, instead of 30 milliseconds, it will become 20 milliseconds, then 10 milliseconds, and therefore you will read this term narrow split second heart sound. In fact, if in some of these cases where the hypertrophy will be even more severe, the aortic and the pulmonic valve closure might become even more closer to the level that aortic and pulmonic valves might be closing at the same time. So no big deal that in the same question, instead of writing the word narrow split second heart sound, he might use the word single S2, or in some cases he might even use the word Reverse splitting would mean that pulmonic valve closure will occur before the aortic valve closure. So every time you read these terminologies which I've written at the moment before you, he's trying to tell you that there is a problem with exit of blood out of the heart. Though less blood came in, still it is taking more time than normal because of the left ventricular outflow tract obstruction. Another auscultatory finding that could be given in this question is S4. This fourth heart sound is again because of left atrial hypertrophy, and then would be the murmur in these patients. The reason for the murmur in these patients, as you can see in the diagram, is one because of the systolic anterior movement of the mitral valve, which is now more obvious in the blue representation, and along with that the septal hypertrophy is contributing to the funneling effect. So the auscultatory finding that would be given to you in the question would be ejection systolic murmur. This ejection systolic murmur, the speciality of this would be that the intensity will become maximum in the middle of systole. The intensity becomes max right in the middle of systole, and then the intensity decreases. So sometimes in the books it might even be written as crescendo, decrescendo murmur. Now comes the important aspect. When it comes to the murmurs, you have to remember the fact, and this I will like to write with a separate color just to get the facts right, that all murmurs decrease with Valsalva, standing, and amyl nitrate inhalation. When I'm saying decreasing, the logic is with Valsalva, with standing, with amyl nitrate. In all of the three conditions that I'm writing here before you, the venous return to the heart will become lesser. And if the venous return to the heart will become lesser, therefore all murmurs will become softer, the intensity of the murmurs will become lesser. The statement I want you to remember is that all murmurs decrease in intensity. The down arrow here means the intensity of the murmur will reduce with Valsalva, standing amyl nitrate. Why? Because venous return is lesser, less blood is coming in the heart. This is a standard information, but HOCM does not follow the rule. I'll explain the reason for that also, but first and the foremost, I want you to remember that all murmurs decrease with Valsalva, standing amyl nitrate, except the murmur of hypertrophic cardiomyopathy. In hypertrophic cardiomyopathy, rather this ejection systolic murmur that I explained to you will become rather louder. In fact, this was one of the statements that was answered to a question in the previous NEET exam per se. I'll give you the logic behind it, the hemodynamics behind it, so please be patient for that. But at the moment, what you need to remember is that the murmur will behave opposite of what happens in a normal person. In routine cardiology cases, all murmurs decrease with intensity, but the murmur of hypertrophic cardiomyopathy becomes louder with Valsalva or with standing or with amyl nitrate. Now let us understand why this is so. We'll go into a bit of fluid dynamics here. You see the volume of blood in the left ventricle, whatever is the volume of blood in the left ventricle of the patient, this would be inversely related to the left ventricular outflow tract obstruction. In fact, in this diagram, which is currently on the slide before you, I can say that if there is going to be more volume of blood in the left ventricle, then more volume of blood will cause separation of this tunnel per se. The tunnel that I've shown here before you, the blue component is the systolic displacement of the mitral valve, and then the purple that you can see is the asymmetrical septal hypertrophy. So if this tunnel will get dilated, then the turbulence will become lesser and the murmur will become softer. Now I will say opposite. Suppose the volume of blood in the left ventricle is lesser, then this tunnel will become narrower. And when I say the tunnel will become narrower, the turbulence will increase. The hemodynamics part, I'll repeat once again. I said volume of blood in the left ventricle is inversely related to obstruction. When there was more blood, there was less obstruction because the tunnel will spread out. And if there's going to be less blood, then the tunnel will become relatively narrower. So that is why I said a inverse relation. Even if you don't get into the fluid dynamics in this space, I just want you to remember that because in hypertrophic cardiomyopathy, on standing or on Valsalva, less blood will come in the heart, less blood will ensure that this tunnel will become narrower. Therefore, the turbulence will increase, and because the turbulence will increase, that is the reason I was saying the murmur will become louder. It is easier to understand the data in yellow because that's relatively easier. Less blood comes in, less turbulence, understandable. But a bit of fluid dynamics is what I've tried to explain here before you with respect to this basic rule that this volume would be inversely related to the obstruction, and therefore the turbulence part will increase, and this will cause the murmur to become louder. In a sense, in a nutshell, I can summarize like this, that the murmur of hypertrophic cardiomyopathy behaves opposite of what would happen in other cardiology conditions. Now, on the basis of this information, what I can say at the moment is that in future, if you are ever gonna be sitting on a medical board and you have to give medical certificate for fitness, like you are a medical officer and you are required to give a fitness certificate to a young guy who needs to be recruited into the Indian army, or let me say police, or forget about these jobs which are highly demanding. I would say even if he is recruited into traffic police, even in traffic police you would be expecting a person to have a certain level of fitness so that he can do standing duty for 10 hours, 12 hours. And these patients who could be having syncopal episodes, in fact they would not be able to do these physical strenuous jobs. In fact, if they accidentally get recruited into the army or police, when they'll make them do those push-ups and chin-ups and pull-ups, then there's a high probability that this person will die. Even if you have to give a fitness certificate to a guy, forget about a fighter pilot. If a guy has done, let me say, a CPL course, commercial pilot license course from USA, 1 CR, 1 crore rupees, and he says, I need a fitness certificate, doctor, so that I can apply to Indigo Airlines or any other airlines so that I can be a pilot there. Then even for a commercial pilot, before you give medical fitness certificate, you need to get a baseline ECG echocardiography done, because if a person with hypertrophic cardiomyopathy becomes a commercial pilot, you can very well understand if he develops a syncopal episode or chest pain during a jet takeoff or during a jet landing, there could be a disaster happening. Let's now look at the workup that would be done for diagnosis of hypertrophic cardiomyopathy, and the best way to identify this condition would be a transthoracic echocardiography. The findings for transthoracic echocardiography is what I have explained to you already, but let me just say the word asymmetrical septal hypertrophy and banana-shaped cavity of the left ventricle just to make you revise the facts once again. If he says what is the diagnostic criteria for this condition, then the left ventricular free wall thickness in this person should be more than 15 millimeter, 1-5. And in case this thickness is more than 30 millimeter, if the left ventricular free wall thickness in a person of hypertrophic cardiomyopathy, if it is more than 30 millimeter, then the chances of sudden cardiac death in these patients, the incidence of sudden cardiac death in these patients will increase dramatically. I will explain to you subsequently what are you gonna do to reduce the chances of development of sudden cardiac death, because after all we as doctors are supposed to save lives. So usually in the exam he's gonna give you a scenario where he's not gonna ask you the diagnostic cutoff which is 15. He will say that the person was having a hypertrophied left ventricle. He'll describe a value obscenely high, maybe 30, 35, and he'll say what can be done for prevention. So I will talk about in the treatment part, but the message is more hypertrophy will predispose these patients to high chances of sudden cardiac death. Another finding that they love to ask, because traditionally whenever I'm discussing any cardiology condition before you, I'm not asking you to remember echocardiography findings, but this is one such condition where rather I'm forcing you to remember these two terms, that is systolic anterior movement of the mitral valve, and second is the asymmetrical septal hypertrophy and increased left ventricular free wall thickness. In fact, in these patients, I can also do ECG, but ECG is not sensitive for chamber enlargement. The ECG of this patient will be showing findings suggestive of left ventricular hypertrophy, and the ECG finding that tells us that there is going to be a left ventricular hypertrophy is that in lead number V1, you would be checking out the depth of the S wave, and lead number V5 or V6, you would be checking out the height of either, the R wave in either V5 or V6. If you combine, you have to add the depth of the S in V1 to the height of the R wave in small boxes in either V5 or V6. If this is more than 35 millimeter, it is diagnostic of left ventricular hypertrophy. But the point is, guys, that ECG is not sensitive for chamber enlargement, which is why we would like to rely on echocardiography as the best way to diagnose this condition. In fact, the third test that I'm telling you, this is relatively invasive, so a person may not give consent for it, that is cardiac catheterization. But still, for the sake of completion, I would like to mention a cardiac catheterization sign for these patients. This would be a longish name. This is called as Brokenbro Braunwald. You very well know Braunwald, the famous author for cardiology, the textbook of cardiology. But at the moment, I'm talking about what is called as Brokenbro Braunwald Morrow, not marrow, but Morrow sign. In fact, this was one of the questions in previous age in PGI Chandigarh. Now we call it INISET, obviously, that Braunwald Morrow sign is a cardiac catheterization finding of which heart disease, that is hypertrophic cardiomyopathy. In fact, there are only two cardiac catheterization findings that you're supposed to remember. One, I've already told you, the longest name, Brokenborough Braunwald Morrow sign. I hope you're remembering it now. And the second one is square root wave sign. This is a cardiac catheterization finding that you encounter in constrictive pericarditis and restrictive cardiomyopathy. So there are only two cardiac catheterization findings that I would like you to remember in the entire field of cardiology, and both have been discussed here at this particular point of time. Now, once you have declared a candidate as unfit for competitive sports, unfit for recruitment into, let me say, army, police, or pilot, the family members of this person will put pressure on you that, doctor, why are you declaring my son as unfit? He always wanted to be a pilot. He always wanted to get into police force. Then you have to explain to them, let me say, this is the only child of this couple, and they say, my child has always wanted to be in these professions. You would tell them that, sir, his heart is not designed for it, because if this guy gets into jobs like these which are physically demanding, he might actually die suddenly. And lots of time, because this is the only child, they may not have that family history of sudden cardiac death in a sibling, brother or sister, so they don't know the dangers that await them, in a sense that they might lose their only child. Now we will talk about the treatment of this condition. So he will ask you drugs which are useful for management, and the specialty why what I'm writing at the moment is asked is because all through in cardiology we always go for cardioselective drugs, like we always talk about metoprolol or carvedilol being used, but at the moment I'm teaching you a non-selective beta blocker, which happens to be the drug of choice for hypertrophic cardiomyopathy. Whenever he says what is the preferred drug, your answer would be given as propranolol. The primary advantage is it's going to decrease the heart rate, decrease the oxygen consumption of the heart, and reduce the chances of sudden cardiac death in the patient. Instead of propranolol, if propranolol cannot be given due to concomitant conditions like, let me say, asthma, COPD, then verapamil can be used. Verapamil will again act on the AV node and slow down the conduction. And if I decrease the heart rate, the advantage for me is if I decrease the heart rate of this patient, then I am conserving the precious fuel that is oxygen, because the ischemia of the heart was responsible for tachyarrhythmias in these patients. Another drug which is mentioned in Harrison for management of these patients is disopyramide. Now this is an antiarrhythmic drug, and apart from antiarrhythmic drug, it has also been documented to reduce left ventricular outflow tract obstruction. If you decrease the left ventricular outflow tract obstruction, then more amount of blood would be able to go out of the heart. The hemodynamics will improve, and this improvement of hemodynamics will then result in reduced effort intolerance. And apart from this, I would say this is also an antiarrhythmic drug. Now, before we go forwards and talk about the treatment of choice for this condition, I would like to mention a quick case before you. Yes, we were discussing hypertrophic cardiomyopathy, but I need to discuss another case so that I can explain the drug perspective to you properly. Now, I have a 20-year-old guy. Let me say I am an intern. I'm working in a government setup, and I have this 20-year-old guy who's coming to me with chest pain at rest. And I have always learned that anybody comes with chest pain at rest, you should be giving sublingual nitroglycerin. So that is what I did in this guy. I instructed my medic or nurse to give sublingual nitroglycerin to this young chap. I thought that the chest pain of this person will improve because nitroglycerin is a vasodilator, it's a coronary dilator, it reduces the preload on the heart, afterload on the heart. So I expected the patient should improve. But what happened shockingly was that after administration of nitrates, there was a chest pain worsening in this patient. In fact, there's also possibility that the person collapsed and lost consciousness after it, and he might even die. Now, Normally, whenever you give nitrates to somebody, the chest pain of the person should improve. So before I describe to you what really happened here, I just want you to tell that this kind of a presentation, that chest pain worsening and a hemodynamic collapse with nitrates is only possible with hypertrophic cardiomyopathy. And if you're wondering what happened here, listen to the main data. Right when I started this topic, I told you in hypertrophic cardiomyopathy, the heart is bigger, but the cavity size of the left ventricle is smaller. As a result of it, this heart will anyway receive less amount of blood. If less will come in, less will be going out, which explains low cardiac output of these patients. Now, what was the problem? The problem was I gave this young chap nitrates thinking that at 20 years of age, it's a coronary event. At 20 years of age, you do not have coronary artery disease. At 20 years of age, you don't have a MI. Usually, you have rather a structural heart disease, that is hypertrophic cardiomyopathy. And the disaster that I did was I gave nitrates to this patient. Nitrates are powerful vasodilators. Because they're powerful vasodilators, therefore right ventricular inflow will become lesser. I mean, if you cause a venodilation, less blood will come in the right side of the heart. If less blood will come in the right side of the heart, less blood will come in the left side of the heart. You see, guys, in these patients, the left ventricle was already smaller. Therefore, in this patient, the stroke volume will reduce further, cardiac output will decrease further, and even the coronary perfusion will decrease further. Let me explain this again. I will repeat my statements here. I said that in hypertrophic cardiomyopathy, already the left ventricle is smaller in size. If you have less blood coming to the right side of the heart, less will come to left side, and already the left side is smaller. So it will receive further less blood. So you can see I put two arrows here to signify that the amount of blood coming to the left side of the heart has been further compromised. This is decreasing the coronary blood flow, and that is rather causing a worsening of this patient, that is causing a collapse of this patient. As an intern, I should have been wiser. I should have realized that at 20 years of age, if a young chap comes with chest pain, it is not a coronary artery disease, it is a structural heart disease, which was mentioned here as a diagnosis. The only scenario in whole of cardiology where you will notice that nitrates administration is causing worsening of chest pain and a hemodynamic collapse with a structural heart disease perspective is hypertrophic cardiomyopathy. To explain this further, let me change the drug. So I'll just use an alternative color to explain this. Let us assume, because this guy, when he came to me with chest pain, he was also having breathlessness. So I thought that, okay, for breathlessness in any patient cardiac case, there is a pulmonary edema component. So I decided to give furosemide. Now, what will furosemide do? It will cause diuresis, and because of diuresis, the less blood will be coming in the right ventricle. If less will come in the right ventricle, less will come in the left ventricle, and if less will come in the left ventricle, already the left ventricle cavity size was smaller. This will further decrease the blood flow and will contribute to worsening of the coronary perfusion of the patient. Yes, guys, a drug like furosemide is contraindicated in hypertrophic cardiomyopathy because it causes less blood to come in the right, less to come in the left, and already there is less coming on the left hand side. Let us try with an alternative drug, ACE inhibitors. Now, we always in cardiology praise ACE inhibitor, but ACE inhibitors also reduce the preload. If you reduce the preload, what's going to happen is that this will cause less blood to come to right, less to left. Already the left ventricular cavity size was smaller, as I've explained to you, and therefore coronary perfusion will worsen. So the learning for you guys is that all the standard drugs in cardiology, whether it's going to be furosemide, ACE inhibitors, angiotensin receptor blockers, digoxin, and even calcium channel blockers. The calcium channel blocker that I'm talking at the moment is amlodipine, not verapamil. Verapamil can be used in this patient, but amlodipine, it acts on peripheral part. It's a vasodilator. It's a peripheral vasodilator, so it will reduce the load on the heart, preload as well as afterload. And once again, the same story will be repeated. Guys, what I wanted to teach you was that standard cardiology drugs, ACE inhibitors, furosemide, digoxin, amlodipine, nitrates, these are drugs which are contraindicated. These are drugs which are contraindicated in hypertrophic cardiomyopathy. They teach you this in pharmacology as well, but I've just reiterated that by giving you the logic behind it. And the logic behind all of these is very, very straightforward. It's the common thing that I've repeated, that all of them will decrease blood supply coming to the right side of the heart. This will decrease the blood supply to the left side of the heart, and therefore there would be a reduction of coronary perfusion, causing a possible hemodynamic collapse and even a sudden death in these patients. At this particular point of time, our next focus after studying regarding the drugs useful for management of this condition would be to focus regarding what would be the treatment of choice for this condition. If he says treatment of choice for hypertrophic cardiomyopathy, we would go in for a ICD, that is a implantable cardioverter defibrillator. This implantable cardioverter defibrillator will be analyzing the ECG. It will record the ECG obviously onto its small computer, but the main objective of deploying a ICD is that it can do abnormal rhythm detection, and usually we get tachyarrhythmias in this condition. So even without the patient coming to know of it, whenever the arrhythmia will start, immediately the arrhythmia is detected, this computer will deliver a DC shock and will terminate the arrhythmia. So the treatment of choice for this patient is implantable cardioverter defibrillator. You see, in all other cardiomyopathies, it is cardiac transplantation which is the first line answer. But for this condition, your first answer for treatment of choice is not a cardiac transplantation, it would be ICD. Now, what are the indications where you would be going in for an implantable cardioverter defibrillator in these patients is, let us say that he gives you that there was a family history of sudden cardiac death, like his elder brother had died suddenly without any warning, so I don't want to lose the second son in the family or second daughter in the family. Another scenario can be unexplained syncope. Why I'm calling it unexplained at the moment is that initially when he became unconscious, the cause was not known. Now we obviously know that there is a chamber hypertrophy and the cavity size of the left ventricle is smaller. It's a malformed heart basically. And the third one is what I've said already, that if the LV free wall thickness, if the left ventricular free wall thickness is more than 30 millimeter, imagine more than 1 inch thick wall of the left ventricle. I mean, how much can coronary artery perfuse? The pure coronary artery, it can transport limited amount of blood. If you have a thickened muscle, then there would be ischemia anyway present in the deeper layers of the heart, and it can get exacerbated during any physical activity. Then he can also ask what other surgical interventions that can be done in these patients. So nowadays we don't go in for open heart surgery in these patients. Now, when I was a student at your age, then what we used to answer for the management of this patient was myomectomy, but that would be an open heart surgery. So nowadays, what the interventional cardiology people have taken over the business of CTVS guys. And if he says what surgical intervention can be done, then we can go in for an alcohol-based septal ablation. In fact, I can say that I've criticized alcohol all through. I've said alcohol on long-term basis will cause dilated cardiomyopathy. It's the commonest toxin causing dilated cardiomyopathy. But I'm praising alcohol here in a sense that we can go in for alcohol-based septal ablation. What I mean by alcohol-based septal ablation is that when we inject alcohol into that asymmetrically hypertrophied septum, this alcohol will destroy that useless muscle, and once you destroy the useless muscle, then the cavity size of the left ventricle will be better than what it originally was, and thereby more blood will be able to come in the left ventricle and more will be able to go out. So alcohol based septal ablation is an intervention that can be done in these patients along with implantable cardioverter defibrillator, and the combination of the two will improve the longevity of these patients. You know, that young guy who was playing football died because he never sought medical advice. Had he sought medical advice, I would have picked up the disease on the basis of a twice beating pulse in systole, a double apical impulse, auscultatory finding of a murmur, and that would have prompted me to get an echocardiography of the patient, which would be a sure shot way of diagnosis of this condition. Moreover, before I talk about other types of cardiomyopathies, it is also important that I speak about this topic of sudden cardiac death once again, because let me say, we are talking about a guy who's playing football at a club level. A guy with hypertrophic cardiomyopathy was playing club football at a colony level and then he died. I mean, that would not be a very intense football game. But suppose a guy is playing professional football and he dies during a football game, then it is unlikely to be hypertrophic cardiomyopathy, because if you are a doctor attached to a football club, your job would be to screen players that I mean, the club should not hire people with hypertrophic cardiomyopathy to play football for them. I mean, the club will have to pay money if compensation in case a football player dies in the match. So, in fact, if he says that in a at a professional level, in a World Cup, or let me say, like in India, we have these professional football clubs like East Bengal or Durand Cup happening. And in a professional football match, if a young guy dies during playing football, then it could be athlete's heart. Now, in athlete's heart, what is the problem? In athlete's heart, the problem is that there could be kinking of the coronary artery. You see, this guy is chasing the ball. Let me say it's the 89th minute of the match, just 1 minute before the referee will blow the whistle, and this guy is getting an opportunity to score a goal, so he's running at the top of the speed, and this guy is a professional level athlete, and his cardiac muscle is pumping blood at the max amount of pressure, and this cardiac muscle itself might cause kinking of the coronary artery, and thereby it might cause a MI, which could trigger a tachyarrhythmia like VFib and would result in death of the patient. So athlete's heart is also to be considered as one of the differentials for sudden cardiac death. Apart from this, I can take up a scenario of mixed martial arts. Now, this is one of the extreme amounts of fighting competitions where you need a super high intense level of fitness and a punch to the chest knocked out athlete. Well, every time there is blunt trauma to the chest in competitive sports like mixed martial arts, then your cause of death would be answered as commotio cordis. Here he will always say that these two guys were in a close combat, a physical combat where knuckles and punches to the chest are allowed, elbow to the chest is allowed, and the blunt trauma to the chest is causing unfortunate expiry of the patient. This blunt trauma to the chest will also trigger a arrhythmia, that is ventricular fibrillation. You see, in HOCM it was again ischemic ventricular fibrillation. In athlete's heart, it is MI that is triggering a ventricular fibrillation. So tachyarrhythmia is the end point in all of them. But the causes can vary, because you see, when I was describing a guy playing football, I never talked about violence. I just said he was chasing the ball. Nobody was tackling him also. Maybe he was himself running with the ball. He did not even come close to dribbling. The one we could have thought that, okay, during a football match, some guy hit the other guy in the chest with his elbow, and that could have contributed to death of the person. Like there was no rough play and still the person died, then it was hypertrophic cardiomyopathy. But if there's a blunt trauma to the chest, like an elbow to the chest, punch to the chest, that is when we have to take into consideration commotio cordis in a patient. And then is a cardiomyopathy that is called as arrhythmogenic right ventricular dysplasia. This is a rare cardiomyopathy given in the new edition of Harrison, where he says there is a fibrofatty deposition in the wall of the right ventricle, and you can see right ventricle or left ventricle, after all it's supposed to be muscle. If you have fibrous material and fatty material in the wall of the right ventricle, this could again be a recipe for disaster that can trigger torsades de pointes or polymorphic VT in these patients. The ECG feature of arrhythmogenic right ventricular dysplasia is called as epsilon wave. Now, I'm not drawing an epsilon wave here because I've discussed this topic of arrhythmogenic right ventricular dysplasia even with respect to Takotsubo cardiomyopathy. This is a separate video on a special type of cardiomyopathy that is called as Takotsubo cardiomyopathy, where I've talked about ARVD as well. So I've drawn the epsilon wave there, and I'm not drawing the epsilon wave at the moment because my focus is to tell you that sudden cardiac death at a competition level, where I'm talking about professional sports, is athlete's heart, or it could be blunt trauma to the chest, or it could be arrhythmogenic right ventricular dysplasia. And if you ruled all of these out, then the cause of death is hypertrophic cardiomyopathy. In your exam, they're not talking about professional football. They're not talking about professional athletes with punches to the chest. If they give you a scenario, then this is the data that you need to answer. But if they give you a routine perspective, young guy playing football at a college level, young guy playing football at a colony level, and he dies, not at a professional level, but at a college level, and he says football player dies. When he says the word football player there, do not be under impression that he's talking about a professional football player. That is intense amount of physical stamina required, and people with hypertrophic cardiomyopathy will not be able to make it there. So they will not be able to reach up to that physical level of fitness. So these are the common causes that we need to understand if there's a sudden cardiac death at a professional football match. Next up, the type of cardiomyopathy that I'll explain is the rarest type of cardiomyopathy, that is restrictive cardiomyopathy. And the question that I'm going to put up to you guys is, what is the commonest cause for the rarest type of cardiomyopathy? Well, the number one cause why this would be happening overall would be answered as amyloidosis. I repeat my statement. The rarest type of cardiomyopathy, the number one cause is amyloidosis. Though there could be multiple other reasons behind this also. That could be in the form of radiation to the chest. Let us assume in a clinical scenario, he might describe a patient who's having superior vena cava syndrome and the radiation to the chest was given. The good news is the SVC syndrome cause became lesser, like it was Hodgkin's lymphoma. The enlarged lymph nodes will shrink, but the bad news is the radiation can cause damage to the heart. Or he might describe a lady who was having recurrence of breast cancer, and subsequent to that, when radiation was given, it resulted in her having termination of the recurrence, but the bad news is damage to the heart will cause restrictive cardiomyopathy. Then you could be having a condition which can not only cause heart blocks, because sarcoidosis has non-caseating granulomas. So these non-caseating granulomas can block the conduction system of the heart, resulting in a heart block, but it can also contribute to restrictive cardiomyopathy. Another important cause to be remembered here is hemochromatosis. There are two varieties of it, primary and secondary. In secondary, the load of iron will be relatively more, but the point is hemochromatosis and sarcoidosis both are causes of restrictive cardiomyopathy. Then even storage disorders that you read in pediatrics, two storage disorders that I can use this opportunity to mention at the moment is Gaucher's disease, that is glucocerebrosidase deficiency, and then Fabry's disease, where we read about angiokeratomas. They both are associated with development of RCM. Then a connective tissue disorder by the name of scleroderma. Now in scleroderma, the name is sclero means fibrosis in the skin, but this condition can be having fibrosis in pulmonary artery. So you have a pulmonary artery hypertension, there's a fibrosis in the lungs, so there's an interstitial lung disease, and worst come worst, scleroderma patients could be having fibrosis in the ventricles or in the heart overall, resulting in restrictive cardiomyopathy. The fifth cause that I'm mentioning is relatively rare, but when you read the name, you will get an idea of why am I calling it as a cause of restrictive cardiomyopathy, because the disease is endomyocardial fibroelastosis. If you read it slowly, fibroelastosis, it tells you there's fibrosis in the deeper layers of the heart. Now the highlight of this rarest type of cardiomyopathy, where the ventricles will be stiff, it's overall a stiff heart, so the compliance of the left ventricle as well as the compliance of the right ventricle will be compromised. In fact, in this stiff heart, I want you to remember the diagnostic criteria is that in the textbook it will be written non-hypertrophied, non-dilated ventricles. He's trying to rule out the other two types of cardiomyopathy, or in simple English, instead of saying non-hypertrophied, non-dilated ventricles, I am saying it is normal size ventricles, but they are stiffer, they are relatively more difficult to dilate. So the compliance of the ventricles is reduced in this condition, and because you are having a stiff heart in this patient, you would notice that the atria of this patient will dilate. So unlike in hypertrophic cardiomyopathy, where you have a ventricular chambers becoming relatively narrow and there's a useless muscle in the heart, the highlight of a post-mortem specimen of restrictive cardiomyopathy will be that they'll give you a heart where the chamber size of the left and the right ventricle will be normal, but the atria will be relatively dilated because the atria have to work against a stiffer heart or a stiffer ventricle. In fact, to diagrammatically represent it, what I have done in this particular slide is I have tried to show in green the fibrosis, and at the same time I've tried to show that the atria of the patient are having to work against a resistance, so they are dilated. In fact, for restrictive cardiomyopathy, if it will be asked to you with respect to amyloidosis, he might even give you a slide. And in this slide, where you are able to see some of the myocytes, there is this pink hyaline deposits which are present. This particular area that I'm highlighting at the moment, where you can see this pink eosinophilic deposit where I put in a star mark, this pink hyaline deposit would be that amyloid protein which is deposited in the myocardium of the heart, making it stiffer, and therefore symptoms of peripheral pooling of blood would ensue, because if the compliance of the right ventricle will be hampered, then blood cannot go in the right ventricle, so there would be peripheral pooling of blood causing a pedal edema. And if the compliance of the left ventricle is reduced in this patient, if you have to work against a stiff left ventricle, then there will be pooling of blood in the lungs. That will explain the pulmonary edema manifestation of these patients. This pink hyaline deposits are those of amyloid protein. So the slide which could be given is that of RCM. I would also like to use this opportunity to mention that if they give you a histopathological slide, in which he gives you these. Normally the cardiac muscle would be in the form of a synovium. All the myofibrils will contract simultaneously, but at the moment I can say the word myocyte disarray. You can see the disordered arrangement of the myocytes. They're going in all directions, because of which the effective contraction of the heart will also be hampered. So myocyte disarray is a feature that is seen in hypertrophic cardiomyopathy. You can see the way these fibers are arranged, and they look relatively bigger and thicker as well. So myocardial disarray is a feature of hypertrophic cardiomyopathy, and in the exam obviously he'll help you with examination findings also, which I've told you would be like pulsus bispherians or an ejection systolic murmur, which behaves opposite of normal. All murmurs decrease with Valsalva standing. This would be rather increasing. In contrast, if they give you a scenario of a flabby heart, if they say it's an enlarged globular flabby heart, and all the chambers are dilated, it's a thinned out ventricle. It's a thinned out ventricle. See, in restrictive cardiomyopathy, I was not saying a thinning, and I was neither saying a hypertrophy. I was saying stiffness, because the thickness is okay. The thickness is normal of the ventricle, but there is fibrosis inside the wall of the myocardium. Contrast this with what I tried to show at the moment in the middle of the slide. That would be a enlarged globular heart, and globularity of the heart would mean that the hemodynamics of the heart would also be affected. And along with this, they'll also give you a histopathological slide where you will be able to see multinucleated, as you can see, multinucleated myocytes. These are damaged myocytes, but the point is, by hashtag I mean damaged myocytes. These multinucleated myocytes are because of various reasons. These multinucleated myocytes could be because of insult by a virus, like COVID-19 was causing COVID-19 myocarditis, and subsequently the same patients were ending up with a dilated cardiomyopathy after maybe 6 months or after 1 year. There was a damage in the heart due to COVID-19 induced myocarditis, or it could be toxin induced as well, or it could be due to sarcoidosis as well. So sarcoidosis you will read as a cause for both dilated as well as for restrictive cardiomyopathy, because in the later part of the disease there will be fibrosis, and initial part of the disease there could be a dilated cardiomyopathy manifestation occurring in the person as well. In fact, when you read the table of cardiomyopathy, you will notice lots of times some conditions would be having overlap, like sarcoidosis and hemochromatosis are two examples or two conditions where they would be written in the literature of both restrictive as well as dilated cardiomyopathy. But there will be some clear-cut distinction. How in the MCQ should I make out? Should I answer dilated or should I answer restrictive? If he mentions the word dicrotic pulse, though I'll give you an explanation for the same as well. But my point is, just like as you guys are comfortable with the word pulsus bispherians, similarly, I want you to remember dicrotic pulse is a feature that is seen with patients of dilated cardiomyopathy. So the first slide that you can see are on the display at the moment. This particular slide, the first one where I put a tick mark, this is myocardial disarray. The second one where you can see the multinucleated damaged myocytes is that of dilated cardiomyopathy. He might give you dicrotic pulse in the question, and if he himself begins by describing a person who had received radiation to the chest, or he describes a patient who's having, let me say, endomyocardial fibroelastosis. The English interpretation itself would tell you that there would be stiff ventricles and the atria are having to work against a resistance. Because nowadays there are integrated questions and they mix up information with pathology. That is why I have incorporated this in the slide for today. And next up would be what would be the clinical manifestations that would be occurring in a patient of restrictive cardiomyopathy. There would be two problems in these patients. One, the compliance of the right ventricle will also be reduced and the compliance of the left ventricle will also be reduced. I am first writing the findings of right ventricular compliance being reduced because right ventricle has less muscle. So the chances of it getting affected or the manifestations of decreased right ventricular compliance occurring earlier would be, chances would be higher because less muscle. So the chances of it decompensated earlier would be relatively higher. The terms that he would describe would be a pitting ankle edema or a pitting pedal edema in the patient. This particular chap has difficulty in wearing his boots or shoes or chappals for that matter of fact, and he will also describe that this person is having ascites. In fact, on reading the word ascites, you might even think in terms of portal hypertension, because traditionally we read ascites with cirrhosis and portal hypertension. But if there is a cirrhosis, then there is a shrinkage of the size of the liver. You will immediately realize that this question is not related to any cirrhotic patient or any patient of chronic liver disease, because there would be a hepatomegaly. Why there is a hepatomegaly? Because if the right side of my heart is stiffer, if there is fibrosis in the right side of the heart, then there would be peripheral pooling of blood. Blood will not be able to come to the right side of the heart, as a result of which there would be a congestion in the liver. Now, he may not write the word hepatomegaly, but he might just write the word right upper quadrant discomfort in this patient. That is primarily because of the stretching of the capsule of the liver on a long-term basis. There is a high probability that on reading terms like swelling in the feet, ascites, and a right upper quadrant discomfort, you still may not be satisfied that this is a cardiology case. You might still be thinking it could be a primary liver disorder, because even in cirrhotic patients, you have a pedal edema. So what is it that's going to be written in the question that will immediately tell you that there's a problem with the heart of this patient? Will be this word, Kussmaul sign. Guys, normally JVP always falls with inspiration, but in this patient, JVP will not fall. Rather, the JVP of this person will rise with inspiration. Now, this is definitely opposite to normal. In a normal person, I said JVP always falls with inspiration, because whenever we take a deep breath, negative pressure in the chest would suck blood towards it. So, in a normal person, JVP falls with inspiration. But if you ride or encounter a JVP rising with inspiration, that is what is called as Kussmaul sign. So that would tell you that this particular question is not related to primarily a patient of chronic liver disease. To help you further, he will also add up in the clinical details that the left ventricular compliance of this patient is reduced. I've written it subsequent to right ventricular compliance reduction, because left ventricle has more muscle, so the chances of it being able to handle the stiffness in the heart would be relatively better. But if you have a reduction in the compliance of the left ventricle, there would be pooling of blood towards the lungs as well. So there would be a pulmonary edema component. How is he going to write this pulmonary edema component? He might describe dyspnea on exertion. He might say orthopnea in the patient, that whenever this patient would lie down in supine position, the breathlessness component will worsen. Because there is fibrosis in the heart, this fibrosis would trigger clot formation. Because of clot formation, he might describe that the same patient would be having increased incidence of cerebral embolism. These patients could be having increased chances of development of embolic stroke. The chances of it, I'm not saying that it will develop immediately. If you start anticoagulation in these patients, the chances will definitely reduce. Along with this, because the left ventricle is receiving less blood, a stiff ventricle, left ventricular end diastolic pressure is more. So less blood will be able to come in the left ventricle, and as a result of it, he might even describe effort intolerance for these patients. So the features that I've described here before you are those of restrictive cardiomyopathy. And now let us look at what will be the workup that will be done in this case. Now coming to the workup to be done in these patients, I will be doing a baseline ECG. And the highlight will be that because there is fibrosis in the heart, there would be a low voltage ECG. Now, low voltage ECG, however, can be encountered in other conditions also. So let us practice. If a patient is having a tubercular pericardial effusion, even then there would be a low voltage ECG occurring in the patient. If there is a calcification outside the heart, this condition where we get calcification outside the heart is usually a sequelae of tubercular pericarditis, but then this would be constrictive pericarditis. The calcification, the calcium which is deposited in the outer layers of the heart could again be responsible for low voltage ECG. Even an endocrine condition, that is myxedema, which is seen with hypothyroidism. Myxedema is after all a lymphedema. So this lymphedema will again contribute to, because there's fluid outside the heart, even if that's lymphatic fluid, doesn't matter. It will reduce or cause a low voltage ECG. So now we know 4 causes of low voltage ECG: pericardial effusion, constrictive pericarditis, myxedema, and fibrosis in the heart. That is restrictive cardiomyopathy. So this would definitely never be diagnostic. When I do chest X-ray in this patient, the X-ray of this patient will reveal a normal cardiothoracic ratio. The question then arises that if I know that the cardiothoracic ratio is normal in this condition, why am I doing a chest X-ray? There are 2 reasons behind it. One is that I want to rule out a differential diagnosis of this condition, which is constrictive pericarditis. So because in constrictive pericarditis, the clinical manifestations are same as that of restrictive cardiomyopathy, I want to rule out constrictive pericarditis because if there's a calcification around the heart, then this calcification that is encountered in constrictive pericarditis can be visible on a X-ray. So that is why I am doing a chest X-ray, because I want to rule out a differential diagnosis. Second, the advantage of doing a chest X-ray will be that it will give me some evidence of pulmonary edema also, because I was saying the patient is having breathlessness. So I need to prove that there's a cardiovascular pathology behind it, and that would be mainly in the form of a bat wing pulmonary edema or prominent upper lobe veins or curly B lines, or information related to cardiogenic pulmonary edema could be given in the question. When I do imaging in this patient, I would be doing a transthoracic as well as a transesophageal echo. Why transesophageal? Because I can scan the atria of this patient, because in this condition, the thickness of the ventricular wall, one of the important diagnostic criteria for restrictive cardiomyopathy is that the thickness of the wall of the left ventricle and the right ventricle is normal. He will write non-hypertrophic, non-dilated ventricle. So you need to demonstrate the thickness of the wall is normal, but at the same time, the left ventricular end diastolic pressure is increased because there is fibrosis, there is a reduced compliance. To aid in diagnosis, we can also do a cardiac catheterization. Now, cardiac catheterization is something that a patient may not agree to, but I still need to discuss this from the academic perspective. Let us assume that this is a representation of the cardiac muscle. So please be patient while I just sketch it before you. I'm going to draw it a second time also. Let me say the yellow that I've shown is the cardiac muscle. I'll be comparing restrictive cardiomyopathy with that of constrictive pericarditis. In constrictive pericarditis, what I have done is that I've tried to show some calcification. In purple, I've tried to show some calcification outside the heart like an eggshell. The diagram on the right hand side is for constrictive pericarditis. The yellow is the myocardium. Whereas in patients of restrictive cardiomyopathy, as is shown in the diagram, per se, there is no calcification around the heart. But the bad news is there is fibrosis in the heart. So at the moment, the white shading that I'm doing, this is for the fibrosis. Now let us see what happens. When the blood will enter in the heart of these patients, it will hit the wall. It will try to stretch the heart but will fail miserably because there is a fibrosis. So the blood will hit and bounce off. I've drawn a vector here only to sensitize you to the fact that the blood will hit the wall, try to dilate the heart, but will fail miserably because there is fibrosis. Contrast this with the constrictive pericarditis, the blood will hit the muscle, fail to dilate it properly because there is a thick zone of calcification that are shown in purple, so the blood will bounce off, and therefore what I am sensitizing you at the moment is for a cardiac catheterization finding that is called as, like in mathematics, no, we say the word square root. So I've shown here before you what is called as square root wave sign. This is the cardiac catheterization finding that is found in these patients, and that is because of the non-compliant ventricle in a patient of restrictive cardiomyopathy. Why constrictive pericarditis was introduced in the discussion is because it is a differential diagnosis of it. So the question might even say, what is the gold standard investigation that you are gonna do for diagnosis of constrictive pericarditis? Then the gold standard investigation that you're gonna do for this case is endomyocardial biopsy. Now, obviously, when you're going to tell somebody that I'm going to take a biopsy from your heart, the person will freak out and he may not give you permission for the same. But this happens to be a gold standard investigation because it can demonstrate fibrosis, it can demonstrate amyloid protein deposition in the wall of the heart. It can differentiate it from constrictive pericarditis. More importantly, because nowadays I can say like this, that patients always prefer a non-invasive method for diagnosis. So in the question, if he uses the word gold standard, then it is okay, endomyocardial biopsy. But if he says what is the preferred imaging modality for diagnosis, preferred imaging modality for diagnosis of any variety of cardiomyopathy, then if echocardiography is also given in the options and cardiac MRI is also given in the options, then I would recommend you to answer preferred imaging modality to be answered for cardiac MRI. Echocardiography is good enough in government hospitals because we do not have the facility for A cardiac MRI, we obviously do a echocardiography, but the bottom line is if they make you compare between a cardiac MRI versus a echocardiography, it's a cardiac MRI. If he just says gold standard, then the answer would be given as endomyocardial biopsy. We'll now focus on the treatment for a patient of restrictive cardiomyopathy, which would again be an implantable cardioverter defibrillator, because that will help in preventing sudden cardiac death due to tachyarrhythmias which can occur in these patients. But if he talks about the drugs that you would be prescribing to these patients, one of the drugs that you will be prescribing is warfarin. Why? Because there is increased risk of cerebral embolism in the patient. These patients can be having a mural thrombus because of the fibrosis in the heart. There could be clotting cycle activation, and therefore you could be having clots in the left ventricle or in the left atria, and therefore these clots could be going into the brain, and I want to reduce the chances of cerebral embolism in the patient. I will also be starting this patient on the lowest dose possible of diuretics. That is because of the fact that when I prescribe diuretics, like if I give furosemide for this person, I would be able to reduce pulmonary edema. But I need to use the diuretics to the lowest possible dose, because you see, after all, these patients are having a low blood pressure also. Remember, there was a stiff heart, less blood coming in the left ventricle, less going out as well. So if I use excess amount of diuretics, I might have a hypotension, and that might cause syncopal episodes in the patient. Apart from this, another intervention which is to be done is cardiac transplantation. I mean, that's the only way that you can get these patients out of this mess and you can improve survival. But if they simply say what is the first line intervention or what is the treatment of choice for this patient, then your first answer would be implantable. You see, after all, cardiac transplantation, I can put him on a waiting list, but he may never get the heart. You see, my point is, ideally, if I just say the fact that if I have to compare ICD versus cardiac transplantation, obviously cardiac transplantation is the final solution for the problem. But if I put him on a waiting list and he dies before it, it doesn't make sense. So to improve the survival of these patients, my point is, why am I writing ICD on the top is that is mainly to improve the chances of survival of these patients. Now we shall be comparing the details of restrictive cardiomyopathy with that of DCM, that is dilated cardiomyopathy. Let's look at the causes behind why do you have a development of dilated cardiomyopathy. The initial causes would be like familial basis. There could be Mendelian patterns of inheritance behind it. Then could be idiopathic, but it is unlikely that he will ask you these two. I mean, familial percentage wise, this constitutes 35% of all cases. Idiopathic is about 20% of all cases. But most of the time, the MCQs will begin after it, because asking familial basis or asking idiopathic would really not make sense. So let's assume a patient who has suffered from viral myocarditis. In patients of viral myocarditis, there could be a concomitant pericarditis component as well. And because the person is having chest pain, the doctor gave steroids. Now, if you give steroids in a viral infection, the possibility is that this virus will be able to cause more damage. In fact, with COVID myocarditis, we were anyway in COVID, no, in moderate to severe COVID, we are anyway giving steroids, systemic steroids, methylprednisolone. So the chances of development of DCM in the patient will increase. If he just says what is the number one cause of viral myocarditis, then it's obviously not COVID-19. COVID-19 was just because in 2020 we had Delta strain causing COVID-19 myocarditis and then subsequent DCM in the patient. The number one cause of viral myocarditis is parvovirus B19. Apart from this, HHV6. Apart from this, Coxsackie B. And yeah, there has been a slight shift. Like when I was a student your age, I used to study Coxsackie B myocarditis. Coxsackie B is the leading cause of viral myocarditis. Currently, it is parvovirus, or it could be COVID-19 as well, that is SARS-CoV-2 virus. Now, apart from this, he might say which toxin contributes to dilated cardiomyopathy. So I was talking about alcohol-based septal ablation for hypertrophic cardiomyopathy, but now I'm blaming alcohol for causing dilated cardiomyopathy. Then could be sarcoidosis, which I have explained to you already. I mean, the non-chesiting granulomas present in these patients, so it could both be causing a dilated as well as a restrictive or a mixed variety as well. The subsequent example is from pediatrics, that is Duchenne's muscular dystrophy. The gene which would be defective in this case is dystrophin gene, which is one of the largest genes that you come across. And these patients will obviously have that waddling gait and pseudo hypertrophy of the calf muscles and recurrent falls in stairs, Gower sign positive. But why do they die? Then the leading cause of death in these patients is heart failure. And that heart failure is because this Duchenne's dystrophy is not only a disease of the skeletal muscle, it is also a disease of the cardiac muscle, which is why DCM is one of DCM in Duchenne's muscular dystrophy is the leading cause of death. Now, ultimately, what happens in the patient is that the heart is thinned out. He will always use the word enlarged globular heart. When I say the word enlarged globular heart, the walls, the muscle thickness, the thickness of the wall of the left ventricle of this patient will be substantially reduced. And I need to demonstrate that this thickness in the wall of the left ventricle and the right ventricle, the thickness of the wall of all the chambers are involved. But I'm focusing on the ventricles mainly because of the fact that you see, you have to compare that in the MCQ with hypertrophic, where the ventricle muscles are more as compared to restrictive, where the ventricular muscle mass is normal. Here it is a thinned out, flabby left and right ventricle. And you need to rule out that there is no ischemia, because let me say, if somebody is having triple vessel disease and the patient is having ischemic cardiomyopathy, then that would be called as ischemic cardiomyopathy and not a dilated cardiomyopathy. I mean, ischemia has to be ruled out, like triple vessel disease has to be ruled out. Similarly, patient should not have had a previous myocardial infarction, because again it would be, if somebody is having a extensive anterior MI and there is a scar in the wall of the left ventricle, even in that patient the cardiac contractility would be less, but it would not be same as a thinned out wall which could be seen with alcohol or with sarcoidosis or with viral myocarditis where steroids were prescribed. I also need to rule out valvular heart disease. I mean, obviously, if there is a valvular heart disease, even then the heart can become enlarged. Like in mitral stenosis, you get a right ventricular hypertrophy, you get a left atrial dilatation. So what he says is that the common causes why the heart chambers can be dilated, you need to rule out. He says you need to rule out presence of ischemic cardiomyopathy, whether you need to rule out whether it is a sequelae to myocardial infarction or whether it is a sequelae with respect to valvular heart disease. If these three causes have been ruled out and you can demonstrate a thinned out wall of the left and the right ventricle, you are able to demonstrate a globular, enlarged, flabby heart, then I mean that would be the English version of it, globular, enlarged, flabby heart. That would be dilated cardiomyopathy, where all the chambers of the heart would be enlarged, in contrast to restrictive cardiomyopathy, where I told you ventricle size was normal, cavity size was also normal, ventricular thickness was normal, but it was atria that were dilated. One of the implications of this would be that in these patients, the tricuspid valve annulus and the mitral valve annulus will dilate. I'm not saying that there is damage to the cusps of the mitral valve or the tricuspid valve. The cusps of the mitral and tricuspid valve are perfect, but there is an annulus of the mitral and the tricuspid valve that is dilated, and because the annulus is dilated, there will be a defective coaptation of the valve leaflets. I repeat my statement. The problem is not with the valve leaflets per se, it is the annulus which is dilated, because of which the coaptation of the leaflets would not happen. If the coaptation will not happen, there can be leakage of blood from LV to LA, and that explains that why do you read about pansystolic murmur of mitral regurgitation and tricuspid regurgitation in this condition. It is because of the annulus dilatation. So let's build a case with respect to this cardiomyopathy. The question will be describing an alcoholic patient. Today this alcoholic has come to you because of the primary reasons that his heart is not working properly, so there would be peripheral pooling of the blood. So this guy is having a pitting ankle or a pedal edema, because there would be a hepatomegaly also, so he can write right upper quadrant discomfort, and because the left ventricle is also not working properly, so there could be features of orthopnea or dyspnea on exertion or shortness of breath described in the question. Now my point is, because in this patient the findings that could be given in the question would be identical to that of congestive heart failure, you would be in a fix that would you think in terms of CHF in a patient or dilated cardiomyopathy. So what will be the examination findings given in this alcoholic, which would tell you that no, this is not a standard heart failure, this is a presentation of heart failure secondary to dilated cardiomyopathy? Well, the key word in the question would be the pulse finding. This pulse finding that I'm describing before you is called as dicrotic pulse. At the moment, I can just say by alphabets, you can remember it: D for dilated cardiomyopathy, D for dicrotic pulse. Well, dicrotic pulse is a very peculiar pulse. I'll draw the pulse tracing also. Why I'm calling it peculiar is that this pulse is not only palpable in systole, but it is palpable in diastole also. You see, I'm saying a very peculiar thing. I said in a normal person, the pulse will peak in the middle of systole. Then there is a dichrotic notch and then the pulse will fall. In these patients, what you will notice is, and I am just sketching it with a different color, what is happening in this patient is that the pulse will rise. The amplitude of pulse will be lesser. The amplitude of pulse will be lesser. The rise would be slightly lesser than what is going to happen in a normal person. But then if you look at the impulse here, what I'm saying is you can feel the impulse not only in systole but in diastole as well. Guys, there is no parallel to this in medical science or in cardiology. I mean, I'm using the word twice beating pulse. And I am saying that this twice beating pulse would be felt both in systole and diastole. You see, pulse is felt only in the phase of systole, no? But if you're having a twice beating pulse both in the phase of systole and diastole, we will say this is dichrotic pulse. And this dichrotic pulse is one of the keywords that would help you pick up dilated cardiomyopathy. Other findings that could be given in the question could be if he goes into heart failure, there could be a loud S1. But if the same patient is having a mitral regurgitation or a tricuspid regurgitation, then he might say soft S1 as well. So S1 per se would not help you pick up the disease per se. I said if it's a frank heart failure, tachycardia could be a manifestation contributing to loud S1. But if it's a chronic MR or a TR described patient who's having not an acute decompensated CHF. He's having a compensated CHF at the moment, then it could be a soft S1 due to mitral regurgitation in the patient. He will also describe a murmur. For the murmur of hypertrophic cardiomyopathy, I was saying the word ejection systolic, now I'm saying the word pansystolic murmur. The highlight of pansystolic murmur will be that the intensity will remain uniform all through the phase of systole. You see, in hypertrophic cardiomyopathy, I explained ejection systolic murmur, the intensity will rise and fall. But in this case, the intensity is uniform all through the duration of systole. So I'm going to call it a pansystolic murmur. Other findings that could be given in the question related to this topic could be like bilateral fine crepitations. That's because of the pulmonary edema component. And apart from this, he could also mention that there is a diffuse hypokinetic because the heart is damaged. It's not able to generate a sufficient amount of power. So he might say a hypokinetic diffuse point of maximal impulse. PMI here means I've used a short form, that is point of maximal impulse, because when you try to localize the apex beat of the patient, the heart is dilated. So the apex beat will be displaced laterally more towards the left, but at the same time it would be hypokinetic because the power generation of the heart is compromised. In the workup of this patient, if he says what is the preferred imaging modality, I've already explained to you that if he gives you cardiac MRI also and he writes echocardiography, then cardiac MRI would be the first priority to be answered in the question. If you are going to run a routine chest X-ray in the patient, the cardiothoracic ratio will be increased. The cardiothoracic ratio is normal only in restrictive variety of cardiomyopathy. Apart from this, evidence of pulmonary edema would also be present. As far as the treatment of this condition is concerned, it would be mainly to deploy a ICD. Apart from ICD, he might also love to talk about another strategy which we are using in these patients. In fact, the problem in these patients is that the left and the right ventricle will not be contracting simultaneously. In you and me, the left and the right ventricle contract at the same time with the same amount of force. But in this case, what's going to happen is the left and the right ventricle may not be contracting at the same time. So a strategy that we might be using in this patient is called as CRT, that is cardiac resynchronization therapy. You see, all patients of dilated cardiomyopathy are after all candidates for a cardiac transplantation. The number one cardiomyopathy which undergoes a transplantation is dilated cardiomyopathy. But if he says overall which is commonest, then I already sensitized you in the beginning. Harrison says hypertrophic cardiomyopathy. Here I have said that the right and the left ventricle are not working in sync with each other. Both are contracting independent of each other, because of which a strategy that I have used in this patient is CRT, that is cardiac resynchronization therapy. This is different from ICD. ICD will deliver a DC shock in the patient. You could be having devices where a single device could be doing CRT as well as a ICD function. So ICD is understandable. ICD is a device that will provide defibrillation if there is a tachyarrhythmia. but it will not handle that lack of coordination between the left and the right ventricle. So nowadays we have devices which can not only ensure that a defibrillation activity can be done, but devices can also ensure that the activity of the left and the right ventricle, the contraction part, will occur at the same time with the same power, so that effective cardiac output can be maintained. In fact, I can put it at record at the moment that if he says what is the leading cause of cardiac transplantation globally, then answer would be given as DCM. Apart from this, additional facts which I want you to remember is that the question might say which cardiomyopathy will be having worst prognosis. Yeah, all cardiomyopathies have a poor prognosis because tachyarrhythmias can occur with restrictive cardiomyopathy, even stroke can occur. I'm just saying on a comparison basis that if he says which cardiomyopathy has the worst prognosis, then the answer should be given as what I've jotted currently on the slide before you, that is ischemic cardiomyopathy. Well, what is the cause of ischemic cardiomyopathy? This is a patient who's suffering from triple vessel disease, and I had told him in 2020 that, sir, you need to go in for coronary artery bypass grafting, but patient kept on postponing the surgery. Earlier he said it's COVID time, then he said marriage in my family, my daughter is getting married, then he says some other festival coming up, so he's delaying surgery. If a person of triple vessel disease has not undergone a revascularization procedure like coronary artery bypass grafting, then per se these patients will develop ischemic damage to all the chambers of the heart. The coronary blood flow of these patients is lesser, so the cardiac muscle will also be hampered. Therefore, ischemic cardiomyopathy, if he says overall has he says which cardiomyopathy has overall the worst prognosis, then the answer would be given as ischemic cardiomyopathy. And remember, the dilated cardiomyopathy diagnosis can only be made if ischemic has been ruled out. So the person should not be having a previous MI, he should not be having a triple vessel disease, and he should not be having a valvular heart disease. Another type of cardiomyopathy that is asked nowadays has an overlap from OBGY, that is peripartum cardiomyopathy. Now there would be a slight controversy in the definition of it. I'll tell you what Harrison says. For peripartum cardiomyopathy, he says, when we are using the word peripartum, it is from the last month of pregnancy. This lady is not having PIH, like she's not having, like you can understand, if a lady is having PIH, she is not taking medication, she can develop hypertensive crisis, and hypertensive crisis can also cause left ventricular failure. So this lady is not having hypertension in pregnancy, but if she develops features of heart failure, she is not having preeclampsia, she's not been previously hypertensive, she does not have any valvular heart disease per se, but in the last month of pregnancy she developed features of heart failure, then it is peripartum cardiomyopathy. The extension is up to 5 months postpartum. In some books it is written 6 months postpartum, but Harrison says that the duration where we use the word peripartum is from, in medicine perspective, peripartum cardiomyopathy is from the last month of pregnancy, that would be 1 month, and 5 months postpartum. As I said, you have to rule out pregnancy induced hypertension, you need to rule out valvular heart disease in the patient, and this lady has unfortunately gone into congestive heart failure. The good news is that recovery is possible, like in contrast to ischemic cardiomyopathy, where I was teaching you that recovery is not possible, and the person has now had a coronary ischemia so bad that all the chambers of the heart are performing suboptimally. In ischemic cardiomyopathy, I'm saying the opposite of that. Recovery is possible in peripartum cardiomyopathy. Obviously, it takes time. Gradually, you need to be titrating diuretics here very, very carefully, so that the pulmonary edema component can be handled. And another cardiomyopathy which I'm mentioning at the moment, though this is described separately, is Takotsubo cardiomyopathy. Takotsubo is a Japanese term. Takotsubo basically is a jar that is used to trap an octopus. Now you'd be wondering how I am coming into talking about an octopus with respect to the heart. So all I want to say is, at the moment, though this is a separate discussion in the HAP, Takotsubo cardiomyopathy is related to catecholamine surge. Like there was an intense emotional trauma. Like this guy had invested, he's 60 years of age, he had invested all his life savings into stock market, and the stock market crashed and all his earnings are over. From, let me say, having 1 crore rupees in the stock market investment, his investment is down to 10,000 rupees only. So this guy suffered from chest pain, and then he collapsed. He developed a cardiogenic shock, that is Takotsubo cardiomyopathy for you. And this is described separately in the app, because anyway here I was trying to talk about the common positions or common types of cardiomyopathies that I am writing. And Takotsubo cardiomyopathy, again recovery is possible. I mean, with use of impella, with use of intra-aortic balloon devices, we are able to make or ensure survival of these patients. So these are the details, guys, that I would like you to understand for this topic. Keep hammering, keep the pressure on, and keep on learning new things every day, and you will definitely break on to the other side.